In terms of toxicity, the treatments that were seen in both groups were similar to what we see in patients receiving intensive chemotherapy for acute myeloid leukemia. There were some differences between the two groups that we have to pay attention to. Quizartinib was associated with more neutropenic infections and more neutropenia than the placebo group. This should be expected since it inhibits wild-type FLT3 at higher doses. It also inhibits KIT, so there may be more myelosuppression to be expected there. So the risk of infection was higher. And most importantly, correlating with that then, the risk of early mortality at 30 and 60 days was higher in the quizartinib group than in the placebo group. And that difference was most pronounced in patients over the age of 60. Still, the incidence of 30-day mortality was less than twice as high in the quizartinib group than in the placebo group. The other toxicity that's worth mentioning, especially based on the development of quizartinib, is QT prolongation. We know that quizartinib, especially at higher doses in the early phase studies, was associated with prolongation of the the QT interval. In this clinical trial, the rate of grade 3 QTc prolongation was 2.3% with 2.3% with quizartinib and 0.7% with placebo. So slightly higher, very similar. There were 2 deaths due to ventricular arrhythmias or sudden death in the quizartinib group that were not seen in the placebo group.